So I will tell you the HepsaNet story. Why we did it, how we did it, and what we have achieved so far. I have nothing to disclose. So the big why. Why did we establish HepsaNet? That was because of this sentiment that we don't have hepatitis B data from Africa. That has been stated a million times in the WHO 2015 guidelines. So if you start reading this one and you look at the research gaps, it says that we need longitudinal cohort studies, especially in sub-Saharan Africa, especially in low and middle income countries, especially in sub-Saharan Africa, and so on. So the bottom line of this guideline was that there is a striking lack of data to inform management from sub-Saharan Africa. So that was the big why. And the key knowledge gap that we were experiencing was this. We didn't really know what were the valid predictors of disease progression in our setting. So, can we predict who will die from hepatitis B in Africa? Does cirrhosis and HCC really occur at a younger age in Africa, like we all believe? Are there any unique risk factors for cirrhosis and HCC in Africa? So bottom line, who should receive hepatitis B treatment on this continent? And then some people say, why can't we just rely on the data we already have from the REVEAL study that was conducted in the 1990s in Taiwan? And that study showed that disease progression depends on host factors, it depends on viral factors, it depends on environmental factors, and probably also something with the society. And the problem is that all these factors are different in Africa compared to Taiwan. It's different human genetics, different environment, different co-infections, and the virus is not the same. They have genotype B and C. Here we have genotype A, D, and E. So what kind of study do we need then from Africa? What we do need is a new REVEAL study. A large study with thousands of patients and 10 years of follow-up, then we would be able to answer everything we wanted to know from Africa. The problem is that we don't have time for that. That will take too long, and it's completely unethical to do a natural history study in Africa, so it will not happen. So what is the solution? The solution is HepsaNet. HepsaNet is a COLDA baby. It was conceived at this conference 5 years ago during the lockdown, the pandemic lockdown. So it was a virtual congress, which is always a bit boring. And what do people do when they are bored? They start chatting. So we started chatting, and we agreed that we have to do something about this knowledge gap. And the idea was very simple. We just wanted to pool the data we have so that we could generate large and conclusive studies from Africa, instead of just publishing small, inconclusive studies from different corners of the continent. So the first phase was very simple. We just collected everything we had from people who had ever published anything about hepatitis B in Africa. And that was all cross-sectional studies. We collected baseline data from 8 countries, which was quite easy, but cross-sectional studies have limited value. They cannot really answer questions about causality and about predictors of disease progression, HCC, and stuff like that. So the second phase, which has been ongoing now already for a couple of years, is much harder, but we collect longitudinal data now from 12 countries, and the aim was to include more than 10,000 patients with at least 1 year of follow-up. And these are the 12 countries, as you can see on the map. We already published a few papers, very practical and very influential papers. This was our first publication. It's already been 2.5 years since this one was published. It was a systematic review and meta-analysis of non-invasive fibrosis markers in Africa compared to a gold standard, compared to FibroScan. And many of you know this study, but basically we showed that the APRI threshold from the WHO 2015 guidelines was essentially useless in clinical practice, with a very low sensitivity to detect people with cirrhosis. And we came up with better thresholds for APRI and for other markers. So Here we identified the best rule-in thresholds and the best rule-out thresholds for advanced liver disease on this continent. This is a very nice graph. It's a lot of super advanced statistics behind it. I'm not going to go into that, but you can enjoy the article if you want to. This was our second paper, also very practical and supposed to solve some of the, problems that people face in their day-to-day life with patients. So we came up with a simple treatment eligibility score, and we called it the HepsaNet score, that can be used in places where you don't have access to Hep B DNA, which is, the main bottleneck on the continent, or it was. So we based this score on ALT, AST, and platelets, and we assigned a score for, as you can see on the screen. And this performed really well, surprisingly well. Without viral load, this score had a sensitivity of 78%, specificity of 87%, which is better than I would assume in the first place. So HepsaNet, as of today, we have a data set with 13,000 patients from 12 countries. All site personnel have been trained in good clinical practice, research methods, hepatitis B management. We have electronic CRF, REDCap, up and running, which everyone has access to. We have an active website for those who are interested. We have hired data managers to oversee data quality, which is absolutely key in a collaboration like this, because there are so many differences between these sites. So to be able to harmonize data across sites, we need that. And we have data scientists to help with the analysis who are present here today. We have published 4 articles, and several are in the pipeline. We have 15 conference abstracts, including at this conference, and we have secured funding from first seed funding from ESOL, and then more substantial funding from John C. Martin Foundation. So what is the vision from here and into the future? The vision has always been to generate conclusive studies from Africa. High-quality studies that will inform guidelines and inform practice. We are working with Africa CDC already to develop African Hep B guidance. And we also want to strengthen the research capacity of our partners so that these partners can grow and be centers of research in their countries. And we want to be a platform for future research ideas. We might move into different areas like immunology, virology, Delta, new drugs, health economics, new diagnostics, and so on. So that is the long-term vision. So we don't have Hep B data from Africa. That was true 10 years ago. It is absolutely not true anymore. We have a lot of good data from Africa. And HepsaNet is a teamwork, and many of you are in the room today. These are pictures from some of our gatherings and courses and workshops. And these are the 12 countries with the PIs, and behind each of those PIs are also a group of people. And we are very thankful to ESOL, who gave us the seed funding, and to John C. Martin Foundation, who has made this possible. Thank you.